And for those joining us as the first time, a warm welcome to you as a new member of the SDR community of practice. Welcome to our growing family. Today we will be talking about the intersection of healthcare quality and physical environment design. And the team and myself are very happy and honored to have you all here. For those who haven't joined the interpretation booth yet, pour nos collègues francophones, bonjour, bon après-midi et bonsoir selon l'endroit d'où vous vous retrouvez en ce moment. Et je suis heureuse de vous retrouver tous ici. Et pour ceux pour qui c'est la première fois, bienvenue à la communauté de pratique SDR. Aujourd'hui, nous allons parler de l'intersection de la qualité des soins de santé et de la conception de l'environnement physique. L'équipe et moi-même, nous sommes très honorés et heureux de vous accueillir ici. So, as you can see, we always make sure that these webinars are bilingual in both French and English, and hopefully in the future we can add more languages. So, right now, I'm just going to give you some time to join the interpretation booth. In the Zoom right corner of your Zoom screen, you will find an icon that resembles a little bit like a globe. So, you can click on it, and I will give you a few minutes to access. Should you meet any issues with accessing the interpretation booth, please let us know. We are available through the chat. And of course, the chat remains available throughout this webinar to share your reflections, comments, and questions. Alors, aussi en français, bien sûr, on fait toujours en sorte que ces webinaires sont bilingues en français et en anglais. Et je vais donc vous inviter, avant que je continue, à accéder à la cabine d'interprétation, car à partir de maintenant, ce webinaire sera surtout en anglais. Et donc, ci-dessous, dans votre coin droit de votre écran Zoom, vous trouverez l'icône qui ressemble un peu à un globe, et je vais vous donner quelques minutes pour y accéder. Si vous rencontrez des difficultés, n'hésitez pas à nous le faire savoir via le chat. Et bien sûr, le chat reste à votre disponibilité pour nous faire savoir vos questions, vos commentaires. Je vais vous donner quelques minutes pour y accéder. Good. Well, this webinar is also recorded and available in both languages for you afterwards. I think I said a lot of things, but I just realized I haven't introduced myself. So my name is Amy. I'm part of the knowledge and learning team of the GFF and very, very honored to be your facilitator today. And of course, we always want to know who you are and who's in the room. So I kindly invite you to rename yourself. There are 3 little dots in the right corner of your screen. When you click on it, you'll have the possibility to write your name. And if you would prefer that, if you find comfortable using, you can also add your role or organization. Good. Lastly, before I hand it over to our moderator, who's ready for the webinar? You can use the chat. Please let us know who is ready for the webinar. You can also use your emoji. Yes, I see a few people who are ready. Great. Perfect. Good. All right, Kate, I will hand it over back to you. Thank you. Have a great webinar.
Thank you very much, Amy. Good morning, good afternoon, good evening. My name is Kate Jutlinska-Katenda, and with my colleague, Kojo Nimako, who's also on this webinar, I co-lead this SDR community of practice. And today we are very pleased to run this webinar for you. We have colleagues from the Institute for Healthcare Improvement and Mass Design, and they will be presenting their groundbreaking collaboration to understand and enhance the impact of the physical space on the quality of care for maternal and newborn healthcare. We have 2 colleagues from IHI. We have Minara Chowdhury. She is a senior director with IHI. She has over 20 years experience in healthcare, operational management, quality improvement, and change management. She has worked on a range of global projects in the UK, across Africa, Middle East, South and Southeast Asia. Welcome, Minara. We also have Pierre Barker, who is the Chief Scientific Officer at IHI, and he oversees IHI's cutting-edge innovation, design, and learning activities, ensuring that opportunities for impact are maximized and that practical improvement methods and tools are accessible to all. Welcome, Pierre. And last but not least, we have Amy Shao, who is a principal with Mass Design Group, where she oversees research focusing on health infrastructure planning, design, and evaluation. Since the birth of her twins, she has championed the design of safe and culturally reverent childbirth spaces. And our moderator today is Dr. Sanam Roda Dewan. She is the lead for service delivery redesign at the World Bank. She is also the Associate Professor of Community and Family Medicine and Health Equity Faculty Fellow at Dartmouth Medical School. Welcome again, everybody. And I hand it back to you for a moment, Amy. Thank you.
Hi, Kate. Are you talking about me, Amy, or presenter?
You.
Okay. Well, I think we can go ahead and go to our presenters already. Thank you.
Okay, thank you very much. So I'm up first. Thank you so much, everybody, for joining. So we're going to begin by talking a little bit about Dr. Paul Farber, who was a medical anthropologist in the US, but worked globally. And in 2016, he talked about improvement and the 4 S's that were needed to really improve healthcare. First of all, systems. How can we redesign and how can we improve systems so that it can lead to improvements in healthcare? How do we engage our staff and bring them on board? How do we consider our staff? So these are things such as your logistics, your equipment. How do we bring all of that together? And of course, the space. And this perhaps is most relevant for us as we go through this presentation. Next slide, please. So one of the things that we've encountered over the last few years when we've talked about spaces to many different healthcare professionals, to governments, to ministry officials is space. Wow, that's going to be expensive and it's going to be all luxurious, but we're a low middle income country. We don't have that luxury to be extravagant. But the point we're making and our learnings really say that good spaces don't actually have to be extravagant. They need to be purposeful, they need to be thoughtful, and they need to be functional and designed in a way that we can really get the most benefit from that space. We also need to use that space as a driver and as an enabler to deliver excellent quality of care. And that may be in a ward setting, it may be in an outpatient, it may be for a mother who's just given birth, or for critical care. So it doesn't really matter where, but space has to be thoughtful and it has to be purposeful as we design them. But at the same time, we have to recognize that globally, there is so much investment in healthcare infrastructure. Every day, every month, we read of new hospitals that are being designed, that are being constructed globally, and that have already been constructed. But the rationale for building those buildings often are sometimes built on an urgent need. We have a growing population, we need to build an extension, a new building. Or it could be, well, in this particular location, we need to construct because that's going to improve access. So we do these things and we think about our population, we think about demographics. More than often, we think about bed numbers, and bed spacing is one of the main things that comes into mind when you think about designing a hospital. But actually, in reality, and in some cases, poorly designed buildings keep on getting built. But really, we do have an opportunity to change this. And as we've traveled to different locations, we've identified how that's happened and how perhaps improved communication or improved understanding of what's actually required could lead to better design buildings. Next slide, please. So this is a little bit of an abstract graphic, but we've been thinking a lot as a team, what's the relationship between the construction or facility physical improvements and quality of care? So our theory and our hypothesis really is that if we do short-term facility improvements, we're not likely to improve long-term quality of care. In fact, what we're going to do is put a sticky plaster over a situation. We'll just change the corridor from here to here, or we just add a little annex here. But the reality is we haven't really solved our main problem of addressing quality of care. Often we do think about longer term facility improvements, and we leverage human-centered design tools, and we think about investment, and we can think about either constructing new or renovating. We might also do some forward planning. And in those cases, yes, quality of care is likely to be achieved. But to fully achieve quality of care, we really need to create a global movement. We need to do systems level thinking, and we need to think about improving infrastructure. Now, what that looks like could be standards, could be guidelines, but could be a more of a very purposeful, thoughtful exercise about thinking for maternal newborn spaces. So this is our theory, this is our provocation, this is what we're thinking in terms of the work that we've been doing. Next slide, please. And we also, our team is actually very fortunate that we are also working in the service delivery redesign space. And as we think about service delivery redesign, as we learn from mothers, their preference for healthcare and how they seek healthcare services, we're learning that space is important and does drive women's decision-making. It could be that, oh, that space is really dark, or it could be that the bathrooms aren't in the right place. It could be that we don't have the right environment to be able to access the care that we want to in the way that we want to. So we really are finding that space is critical to successful service delivery redesign. Next slide, please. But we have to think that really, as we think about maternal care, maternal and newborn care, and we think about how we want to promote a healthy life, we want to ensure that every life is healthy. Thinking about space and integrating it with clinical care, with operational processes, is something that will really help us think about how we can support our mothers as they go through the birthing process. Next slide, please. And as we think about global maternal and newborn care, there's an opportunity to really align some of the work that the global donors, global partners are doing, so that this isn't in isolation. If we think about space holistically, not in isolation, then we're more likely to integrate space into existing programs and to be able to create that momentum and that urgency around addressing space. But we have to invest in both access, quality, and to do that, we need to think about our space. Next one, please. So a little bit about IHI. So that was a little bit of context on why we're thinking about space and what is our driver behind working for space. So the Institute for Healthcare Improvement has a vision that everyone has the best care possible, and we wish our mission is to improve health and healthcare worldwide. We work in 42 different countries, and we really pursue safe and equitable, high quality care. We look at improving capability, and we have other programs around joy in work and health equity. But really, we want to also improve the health of our population. And we want to be able to innovate and spark innovation, spark action. And a lot of the work that we're doing around maternal newborn spaces is really with this in mind. Next slide, please. So I've covered some of this. We have 18 global strategic partners, and we've also, through some of the work that we've already done, have around 6,500 fewer women who are experiencing emotional harm from some of our work on better maternal outcomes. We've done some work with the nursing home. So we have a huge range of projects that we work on, improvement initiatives. But we are a very global organization that's working on maternal health in many different countries. Next slide, please. And Amy, that's over to you.
Hi, thanks for being with us here today. So beginning in 2020, IHI and Mass Design Group began collaborating to champion the design of improved childbirth spaces. So Mass is a nonprofit architecture and human-centered design firm based in Kigali, Rwanda, and Boston, Massachusetts. And we've worked on health infrastructure design and standards across global contexts. We were founded on the idea, on the premise that design is never neutral. It either helps or it hurts. And our work over the last 12 years demonstrates that well-designed spaces can transform how people access health services. It can amplify care delivery processes. It can improve health outcomes, and it can support care experiences that are dignified and respectful. And I think the point that we want to make in showing all of these kind of examples of work around the world, as well as some very simple examples, is that you don't have to Manara's point, do something extravagant to make a radical difference. This is one of our earliest projects in Butare, Rwanda, where instead of a traditional ward layout where you have beds lining the walls with patients looking at one another, we thought, what if we were a sick patient, the last thing that we would want to look at is another sick patient. So we inverted the beds to face away from one another. And the goal of that was to improve patient privacy and comfort. We have this half-height wall down the middle that allowed us to run medical gases and support very efficiently, and opened up the exterior walls for natural light and ventilation to reduce the risk of infection. I'll hand it back to you, Manara.
Sure, thank you. So we have to ask ourselves the question really that how can we better improve the quality of maternal newborn care? How can we deliver more to really support our mothers and the newborns? Next slide, please. So in 2020, we started, as Amy said, started a partnership with Mass Design. And through some donor funding, we worked on a project to really learn more about the relationship between space and quality of care. We had two focus countries, both Ethiopia and Bangladesh, and we used a human-centered design process to really understand, first of all, women's health-seeking behaviors in the facility, but also extended this to understand how the providers felt about the facility, how that influenced how they delivered care, how the community influenced mothers. So we really looked at a lot of the influences, both from the mother's perspective, the community, the relatives, but also the staff and ministry officials at the central level. And we came together and we recommended with the country teams some improvements to facilities. And we'll share some of that with you later on in this presentation. And we'll take you on a deep dive of facilities that we've designed in both of those countries. Next slide, please. So we've also really brought together all of our learnings into a toolkit, and that's available. It's an open source resource that's available on our website. We can share that link with you. And that really does help to explain the entire process, all of the tools are available there. But really what we're thinking is that if we were to go through this process, we will strengthen the information that we receive regarding spaces, and we'll be able to use that more effectively as we design spaces so that they're more functional, they're more relevant, and they meet the needs of the people that we serve, as well as those that are providing the service. Next slide, please. So I am going to hand over to Pierre. Pierre, over to you.
Thanks so much, Minara, and great to be with you all. I'm going to make a couple of points here around the sort of clinic. I'm going to give you examples of 3 clinical scenarios in which this issue of space is really so important. And it really delves into the point on the screen here, which is that we have a huge array of evidence-based interventions at our disposal right now. But the problem is really implementing them. And the focus here is what are the right spaces that are required to implement evidence-based interventions. And the first one I'm going to start with is kangaroo mother care. Now, I'm sure most of you are very familiar with this concept of keeping mother and baby together from the time of birth for the first critical period, which extraordinarily, if done well, has been shown to decrease mortality of small newborns by about 40%. And you'd think that with such a dramatic result, that this would be widespread use now across all countries, not just in a hospital setting, but in any setting where babies are born, whether it's in primary care in the hospital, whether it's back in the home. And the interventions required or the adaptations of the environment required are really very simple. There needs to be some space for the mother and the baby to be alone. There needs to be some simple equipment, as you can see here, adaptation of a bed to allow the mother to be in the sitting position, because keeping the baby close to mom is not that comfortable unless you provide some space. And also there needs to be a sequestered quiet area in the ward, a designated space which allows this to happen successfully. Those of you who've been into the areas where kangaroo mother care is being implemented, I'm sure have seen a huge variation in how this is being implemented, from the quiet, ideal situation with the appropriate equipment, which, as I said, is really very basic, to makeshift curtained off parts of wards, which are really not conducive to what is essentially a very difficult task of continuously keeping the baby with the mum for very long periods of time. So just a little bit of a thought into a very low-cost space intervention like this could result in a very dramatic change in the mortality outcome for small babies. The second clinical situation that we can talk about is mother newborn care units. Now, this is a step somewhere between kangaroo mother care, adopting a lot of the principles of kangaroo mother care, and a full-blown neonatal intensive care unit, which you'll see more commonly in some of the regional hospitals. But this model, again, which is very evidence-based, has been shown to save life, does need space. Unlike a NICU, again, there is a major encouragement to keep the mother and the baby together. This requires the baby, this requires a separate space for the mother to be adjacent to the baby at all times. It requires other spaces to allow the mother to stay close by a bathroom, the ability to be able to change clothes coming in and out. And we know that this kind of additional request for space or burden of space is difficult to ask for. But again, looking at the extraordinary benefits of this type of intermediate unit and the money that it saves for not requiring full-blown neonatal intensive care units, which is usually where a lot of the hospitals will go to for more intensive care, can save a lot of lives and a lot of money. The last example I want to briefly discuss is again an intervention that is very strongly backed by evidence. If we allow mothers more mobility, more flexibility in how they deliver their babies, different positions, the ability to walk around, some very low cost equipment like the ball you see here in the left hand corner, that allows moms to relax and stretch over while in labor, makes a huge difference. But these have to be thought through, and there has to be the belief and engagement of leaders to allow these kinds of spaces to be created, walking spaces which allow quietness and privacy, as you see in the top left-hand corner. So I'm going to hand off back now to Amy, sorry, to discuss a little bit more about how we went about understanding what the space needs and coming up with some of the solutions. So back over to you, Amy.
Thanks, Pierre. And I'll just add one more to your list of three, that we know that there's a lot of evidence showing the importance of companions for providing physical and emotional support, but very rarely are they kind of intentionally accommodated in the design of spaces. They really have a potential to be part of the care team in a way that's not only good for the mother, but helping to offset the burden of care on providers. But usually they're very much an afterthought. They're just, there's no space for them, and they just have to say, go outside, sit over there. And because of that limitation on space, they aren't able to be harnessed as part of that care team, and often are excluded from the interior wards where they could be providing support. So more intentional design could include simply putting a chair next to the bedside of the mother, or in an ideal scenario, for example, in postpartum wards, including a bench for them to be able to sleep and stay for longer periods. So this next kind of mini chapter is really about right care at the right place. And the point that we want to make here is that it's not enough to just have the spaces. You really have to strategically arrange them in order to allow for the necessary care flows leading to better health outcomes. So at the regional scale, I think there is some understanding of the importance of distributing referral facilities so that people do get the right care at the right place, and from effectively accessing trusted community-based care up to life-saving procedures. And some of the focus of the service delivery redesign approach is really based on that recognition that certain levels of care are underutilized. So effort is being put in to understand what drives health-seeking behaviors and seeing if we can better drive care at those kind of gap areas. But at the building scale or at the facility scale, there's less attention paid to the proper distribution of spaces. As many of you know, facilities evolve additively over time, leading to kind of tangled spaces that are not aligned with care flows. So this is an example in Bangladesh of a facility that got added to over time. There's a series of buildings here. And when we came in and assessed this as part of our Deliver More work, we saw that the maternal spaces were distributed across all of these buildings. So they didn't have designated of labor and postpartum wards. They had beds within the general female ward, which was so far away from the delivery room. You have to go through the ward, through the central space, down a long corridor, through the OR complex, and over here for delivery. It was so far that they ended up making this makeshift curtained off area and having deliveries in this tiny corner over here. So there's this kind of tangling or kind of strange distribution of spaces that we have an opportunity to think about how can we untangle that and how can we better consolidate spaces. So we won't get into the details here, but this was the proposed design on another level of this facility that really tries to consolidate all the necessary spaces together and make sure that the right care and resources are at the right place. And the point here is just, we really cannot approach facility design as a checklist. So often standards say, do you have a delivery room? Do you have an operating room? It's not just about whether you have them, it's about how they're co-located together. Well, Pierre, I think I'm handing it back over to you here.
Thanks, Amy. Yeah. And so when we think about ideal spaces, we need to, we're thinking in sort of three broad areas. The first is where the facility itself is located. The consideration here is to ensure that there are that the facilities are located closer to where people live, but also that the facilities are an attractant, that they are created in such a way that people really want to come and seek care there, that they have enough capacity for the patient volume, and that they are known within the community to be places where care is safe and where mothers can receive dignified care. So these are all considerations in planning in terms of where the facilities are located, but also what the aspiration is within the facility to create an attractive facility that people will want to actually come to. The second is what happens once the mother gets to the facility. And often, as many of you who will have been into these types of facilities will know that it's really very difficult to navigate through the facility as you're coming in, and navigating crowds and queues, but also when you're in, the space can be created to enable much more efficient and safer movement of patients through the facility, introducing triage areas, making sure that there's the sort of proximity that Amy was speaking about between emergency care and further care for referral within the structure. And these are all planning elements that we're paying a lot of attention to. And then for mothers who have to stay within the institution, making sure that there are facilities that, again, are conducive to staying. One of the biggest impediments that I saw, certainly in the work in Malawi, was that mothers simply weren't prepared to stay in the hospitals because of the conditions that they were expected to stay in. So making sure that mothers who need to do kangaroo mother care or who need to stay on for postnatal care are given the types of environments that will actually encourage them to stay rather than to leave the hospital prematurely. So, and over to you now, Manara, to talk a little bit about culture and place.
Thank you. So as we continue to take you through our space journey and our thoughts around why space is so important, one of the things that we certainly shouldn't overlook is honoring our culture and place. And as IHI has done this work in many countries, as I'm sure many of you have visited maternal newborn spaces in different countries, we know that there are very special and meaningful cultural practices that take place either during or immediately after birth. So in some countries, we need to think about prayer spaces. In Ethiopia, there's a traditional coffee ceremony where we need to have that space, and mothers expressed that they need that space to be able to do that immediately after birth. We've heard in different places that there may be other space requirements where there could be religious rituals or cultural practices which they conduct immediately after birth. Usually, mothers don't want to wait till after they get home. These things are important, they're culturally relevant, and beliefs that are very special and unique to each individual. So respecting and recognizing that within our physical space really helps to create that bond of trust and belief in the healthcare services that are provided. Next slide, please. And Amy, this is you.
Yeah, and I'll just make one more point on this slide, that I think accommodating cultural practices is not just a nice to have. It's not just something that we do out of respect. It actually is really integrally tied with being able to provide care, because to Pierre's point, encouraging mothers to come to health facilities for care involves convincing them to sometimes depart from traditional at-home practices. And so in places like Ethiopia, we found that accommodating a traditional coffee ceremony was a really big driver of getting women to come and to stay in the first place. So it's not just this nice to have, it's really critical to encouraging facility-based care. And then this slide is about, we can also honor culture in place by thinking carefully about what the buildings themselves are made of. We can use local materials that feel connected and rooted in place, that also have the advantage of engaging community in the training or job creation process. And it's also an important opportunity to think about reducing embodied carbon and often too reducing cost of importing materials as well. So that's a good transition to this last subsection, which is about connecting climate resilience, the bigger picture of our global planetary health and our individual and community health. So in this day and age, it's very clear that our health is linked to the health of our planet. And there are a lot of components required to build climate resilient health systems, but infrastructure is one of the most overlooked and under-leveraged. So health system leaders and funders commonly acknowledge the importance of essential systems like water and sanitation and hygiene, waste management, as well as sustainable energy provision. And we agree, this is very important. It's across many contexts, we've seen, when these systems break, it really impedes the quality of care and the safety that we're able to provide. When women are leaving health facilities because they don't have running water to bathe or to go to the bathroom after birth, when there is waste or placentas that are being disposed of in ways that are not safe. People understand the importance of these essential systems because it's very clear whether something is working or not. And yes, we have to make sure that all of these essential systems work properly, are functioning long term. But achieving climate resilience requires thinking bigger and shifting from a mindset of mitigation to one of restoration. So beyond trying to add solar panels to provide a sustainable source of energy, what if we lived in a world where buildings were designed for their climate context in the first place, and thereby improving the comfort on the inside and lowering the necessary energy consumption and addressing disease transmission. So these photos from Butaro Hospital in Rwanda, a hospital that is soon to be under construction in Bangladesh, and one that is just completing construction in Liberia, are all examples of ones where you harness cross ventilation, stack ventilation, et cetera, to try to make those buildings more suited to their climate and lower the carbon footprint. And then beyond, more thoughtfully selecting sites and building structures that don't fall down, imagine a world where infrastructure is poised to respond to climate disasters and pandemics. And this example of a hospital designed in Bangladesh was designed very intentionally to accommodate flooding. So there are zones that are meant to be porous and allow floodwaters to settle while still allowing the kind of passageways and walkways to stay higher. And it was also designed to accommodate a future pandemic by co-locating the hospital and medical school into one larger site, so that during a pandemic, the medical school could provide spillover space for additional care and spaces that are needed. And the ventilation systems, both natural and mechanical, were also designed in anticipation of that kind of scenario. And then beyond conserving resources and minimizing disruption to our environment, imagine a world where we could foster health by balancing and restoring ecosystems. So this example of a hospital in Liberia was designed to promote a regenerative landscape. So we went and looked at the existing site. We found that it was very swampy, which in some ways was not ideal for a hospital site, but we realized that there was an opportunity to enhance and restore the existing wetland, which was very low-lying and breeding mosquitoes. So by improving the wetland ecology, making steeper banks and really trying to bring back a healthy ecology to this site, which was connected to a broader regional wetland system, it's important for not only the kind of health of this local ecology, but also influences human health when you're able to kind of restore that balance and mitigate things like mosquito-borne illnesses. So stop here. I think, Sanam, I'll pass it over to you for pausing and reflecting on some of these before we continue to the second half.
Thank you, Amy, Pierre, Manara. So yeah, we just wanted to take a break and hear a little bit from the group about why space matters. Why does it matter to you? And as I was thinking about this question, I think the you could be as a health professional. It could be you as someone who's been a patient. I think many of us have been through healthcare facilities, either with loved ones or ourselves. So why does space matter to you? Feel free to drop your thoughts in the chat or raise your hand. Asma Ahmed, please go ahead and introduce yourself too.
Yeah, Assalamu alaikum. Yeah, hi, my name is Asma Ahmed. I'm calling from, I am not calling, I totally forgot that. I'm from Somaliland and works with the Nursing and Midwifery Association, and has been living overseas all my life. So I've encountered working in different settings, different infrastructures, and seeing the changes in developed country and now back home in my country. So I was always thinking, I've seen it where they didn't have, the settings did not go with the patient care. And the patient satisfactions or them looking at the place as a healing spot or healing space was gloomy. So it really hindered their recovery process or even seeking out help. So, and nurses and midwives feeling like the settings does not involve their input, because you need the input of midwives and nurses on whatever setting you're doing, because they know how to save time and effort and in doing procedures and attending to their patients. So I believe 100% the infrastructure, as you have explained it, and all the different facets of it, it's an essential part. And I think people think you build a hospital, you build a unit, few rooms, but there's more to it. It helps in the recovery of the patient. It helps in reducing wasting time for the midwives and nurses. And also it helps in people seeking the place. and not avoiding it because it's not welcoming, it's not spacious, and so on.
Thank you, Asma. I think that really sums it up. It sends a message of respect to our providers and our patients, right? That we care what their experience is like. Other thoughts? Sharon, I'm gonna have to call on you. I'm sorry. So Sharon Rising says in the chat, do you want to jump in?
Sure, I could just share a couple of thoughts about this. I think we've, as we have worked for many years with group prenatal care, we've talked a lot about the importance of safe space for our groups, and that's sometimes been a hard concept to get across because our facilities aren't built with really wonderful group space that will allow for privacy because, it's also care. So allow for privacy as well as just an encouragement to women to come. And as you see, women come in many places. I've seen women come into space and they just take a big breath and like, oh, this feels so wonderful. It's so different from sitting for long periods of time in a waiting room. And here's a place where they can come and relax and get to know each other. And as we see frequently, really share issues of importance to them that they've been unwilling to share with anybody else. So space is a big issue, and it's often a very difficult system issue to solve. So good to hear some of the comments here. Thank you.
Thank you, Sharon. For those of you who don't know, Sharon Rising, she's the founder of the Centering Healthcare movement and the group visit movement in the US and globally. So thank you for joining us. I definitely remember running group visits, and we happened to have a sink and a refrigerator in our group visit room. And that allowed us to make baby food and to talk about nutrition in a way that we couldn't have otherwise. So small things like that, I think Amy was saying, like, these don't need to be high cost innovations necessarily, but they need to be thoughtful and purposeful. So thank you. Others? So, Bruno Boucher, would you like to jump in or shall we read? Bruno says, go ahead, Bruno. I see you coming off of your mute.
Sorry, I was struggling with the mic. Sorry, apologies for that. No, I don't think anybody would question the relevance of addressing what we call the space or the safety, the cleanliness, the convenience of any building where that is designed to deliver care to anybody, not just for mothers and children. But I'm also wondering, and we've all seen, like I've said in this, I've visited, I don't know how many, over 30 years, how many facilities, and it's always the same, depressing photo or picture of this, broken windows, no screens, mosquitoes, the noise, the mess, it's not clean, and anyway, we all know that. But I'm wondering, how much does it cost to do this, and where is the money going to come from in low and middle income countries, obviously? And it's not just about building or redesigning, it's maintaining it in good shape. And we all know about these white elephants, like we call them, brand new hospitals, and the minister cuts the ribbon, and anyway, we all know that. And then you go back 3 years later. First of all, there's no staff to staff these places, and it's too big, and the maintenance costs are simply not there. The running costs are not there. So I don't know. I'm struggling a little bit with not just the concept and the willingness or the importance of having, clean facilities, that's the minimum, and functional ones. But how realistic is this, and how many? I can't imagine the billion of dollars that are going to be needed in all the countries that where we work, and where people do not get the minimum, the basic quality of care, including the space here, or this dimension, this space dimension here. And where is it going to come from? Has a study been done? And where would the money come from? I'm sorry if there is no answer to this, but that's the first thought I had when I looked at the beautiful design in Rwanda, which we always cite Rwanda because it's the exception, but yes, that is the exception. So anyway, if people have some participants have some beginning of an answer on this, I would be very interested, obviously. Thank you.
I'll hand off to Amy, who's going to, I'm sure, give us a good answer to this. I think, Bruno, you raised such great points. I think there was an image that we showed early on. I think we may even show it again later on in this thing. Hospitals are being built every day, built, and I think what we're saying is that there are choices that could be made. So I think what we're trying to do here is show the importance of space and of thinking ahead about the kind of care conditions that are affected very deeply by space considerations, whether they're within the room itself or the connectivities of the spaces within a hospital facility. But money is being spent on building, as you say, which often ends up with a kind of a white elephant type product. But Amy, this really gets to the heart of why we're doing this and the blueprints that are being developed to really help planners think ahead about how things could be done differently.
Yeah, thank you, Pierre. Yeah, I think I want to make 2 points here, and thank you for that comment and question, Bruno. I guess the first point is that if we go back to Paul Farmer and drawing inspiration from him, Paul said something along the lines of, we have to look at not just the cost of doing this, but the cost of not doing this. And I think one of the reasons why our partnership with IHI has been really fruitful and really collaborative is they approached us. They realized, we were doing all of these interventions to try to improve care, but we're not the kind of pinch point or speed bump that we're encountering is space. We're not. I think to was it Ozma's point or somebody earlier, providers and implementers are doing the best they can in spite of spaces, in spite of their inherited conditions, which commonly work against them. And what would it look like to make some tweaks, not monumental tweaks, but better ones, so that they can work because of their spaces, not in spite of them. So if the first point is the cost of not doing this, the second one is we need to right size how we are investing. It's not that no money is being spent, it's that we see waste all the time as well. I know I've seen poor facilities be built where either some technical things are missed that are really silly. So for example, an OR built that the ceiling's too low and the structure can't bear the weight of the equipment, so then it's scrapped and not used. Or in Liberia, for example, health centers that are built using a prototype model that really wasn't well a good fit for that climate and context in the first place. But in addition to that, being built in a way that, for example, the ramp ended 6 feet above the ground because it was designed for a flat area, not a sloped area, and nobody could get up onto the building. So a lot of things that are very unfortunate in terms of implementation, but also waste when the right people aren't engaged in a kind of human-centered process in informing the design of those spaces. And you also see a big mismatch between spurts of money that are injected at certain points. For example, millions of dollars in an Ebola, I don't remember what they call Ebola treatment unit, but then by the time it was built, Ebola was maybe on its way over, and that money could have been really well used for kind of long-term permanent care in that region. So money is being spent. I think our goal is how can we don't need to aim for everything being super fancy. How can we aim for the most bang for the buck, and really being smart and incisive about where we think we're going to have the most impact to improve things.
Great, thank you. I want to pass back to Manara. I think some of these questions are going to be addressed in the next set of slides. Thanks so much.
Yeah, thank you. Amy, can we get the slide deck back up, please?
Yeah.
So absolutely, I think as we take you through the remainder of our presentation, I think you'll come to learn, first of all, a little bit about the global goods, and then we're also going to share a couple of case studies with you where we'll talk very much around how we can be cost effective and how we can think about renovation, not necessarily a brand new build. But we'll come on to that in a little bit. So the global goods. So we talked to you earlier about two case studies that we worked in, two countries that we worked in, Bangladesh and Ethiopia. And you might be sitting here thinking, well, that's brilliant for Bangladesh and Ethiopia. What about the rest? How can this be relevant? How can we have learned sufficiently from these two countries to be able to say we have a set of global goods? But through this collaboration, we've really been thinking about how we can start to learn about the general aspects of maternal newborn care, which irrespective of country or irrespective of region, must and should be there. And some of these are guiding principles which we need to adhere to. And you've heard some of them today around clinical care, around honoring culture and local using local materials. So some of that we've talked to you already. So our Delivering More toolkit, next slide, please, begins with a primer, which is really the executive summary of the project. It documents our process, how we went through this, why is it that we're actually doing this work. There's actually a film that accompanies all of this as well. So please do go onto the website. I think somebody's colleagues chatted in the link. Please do go onto the website and you can certainly learn more. Next slide, please. We've also created a facility design guide. We understand that for countries, for systems, health systems, for teams within a health facility that are considering renovation, that are considering reconfiguration of existing health facilities or brand new facilities, may need to go through a specific process. There is a facility design guide which really goes through the stages of a design process and explained which stakeholders should be engaged when. So that's all of the space programming is included there. So a lot of technical information is certainly included there. We have an engagement tool. This particular image that you're seeing is one that was translated into Bengali. We have already the toolkit translated into Amharic, but there will be no doubt as other countries adopt this and take this forward, this can also be taken forward into different languages as we go through this. Next slide, please. We have a facility assessment tool. This will predominantly be used by the engineers. So there's real guidance on how to consider space. Should it be a new build? Should it be a renovation? Should there be an extension? Thinking about structural, thinking about wastewater and water supply, thinking about medical waste, thinking about all those factors that sometimes get missed and get left till the end. But, one of the things that we had Bruno say is more around the sustainability of the facility. How do we staff it? How do we maintain it? So thinking really about the electrical system is also really important. So all of this is included within the facility or the assessment tool that's designed for the facilities. So here are the global goods, which are design principles, which can be taken forward into any setting. They will obviously need a level of customizing. They'll need a level of tailoring to suit different country contexts. but certainly they're a great place to start and a great aid in terms of developing a new facility. So this particular section is on outpatient care, and the next one is on inpatient care. So these are really clear guidelines on how those areas should be designed. Next slide, please. And we have our design case studies. So Amy is actually going to be taking us through our design case studies. And again, from this, you'll learn about some of the best practices that we've adopted as we've designed these particular environments in both Ethiopia and Bangladesh. And this is an example, just on the previous one, is an example of an inpatient ward, actually, where this is an existing building, and this is actually in Bangladesh, the top right-hand corner, and the government actually said to us, we do not wish to build new buildings, we have them already, but how can you reconfigure those spaces to make it more functional, make it more effective, and make it fit for purpose? So this is an example of how internal reconfigurations can be applied to an existing setting and really maximizing the value of that facility. Next slide, please. So we're currently into phase 2 of our work. That was phase 1, where we actually looked at a number of different areas across the 2 countries. What we're now looking to do is to provide some specific technical country support and also look at global dissemination, because we recognize that talking about this in a very limited group may not be giving us the right springboard globally to actually take this forward and for it to be important and meaningful. Next slide, please. So our country technical support at the moment has been focused in Ethiopia, Bangladesh, and Kenya, where we continue. In Kenya, we're actually looking at some group antenatal care spaces, and also looking at postpartum hemorrhage, whether any specific space requirements are there. In Ethiopia, we continue to look at NICUs or MSCANUs. We're looking at other areas such as IKMC. And in Bangladesh, this time we're focusing on developing the generic guidelines for primary care. So how do we deal with antenatal care and postnatal care in the primary healthcare setting? Next slide, please. So as we gear up for our global dissemination, we're actually thinking about how do we develop this case for change? We need to create a momentum and a movement behind this work so that really it does grow and it does become important, not just for new buildings and new constructions, but actually thinking about our existing spaces. And going very much back to what Pierre and Amy have just said a while ago, we're thinking also, how do we embed this work into systems so that as systems themselves renovate existing facilities, that they take the opportunity to really enhance the environment for mothers and newborns. And having worked in this space for a number of years now, we recognize that there are always opportunities to make changes to our environment. There's always reconfiguration happening, but why not take up that opportunity and say, okay, let's look at the best practices. Let's not just do what we always do. Let's disrupt the current process and let's actually think about having an effective system. So this is something that we're really thinking about. How do we facilitate and enable that discussion for this to be at the forefront of people's minds? Next slide, please. And now I'm going to hand over to Amy, who's going to take us through a little bit of the case studies. Amy.
Thanks, Manara. So yeah, we'll do a quick run through of some examples that show how thoughtful design can be applied to very specific inherited facilities and contexts. And these are really meant to show how we need to strike a careful balance between what is ideal, the best possible outcomes for care, but also what's realistic and implementable. So this was the example that Manara showed earlier on one of her previous slides, Munshiganj General Hospital in Bangladesh, where the existing women's maternity services was in this older building here, but they were in the process of finishing the construction on this new several-story building over here on the right, which had the potential for vertical expansion. When we looked at the plans for how they were going to be finishing out the interiors of the spaces, we noticed that the maternity ward was on a different floor from delivery and labor and OT, and also that the NICU was in a very tiny space that was connected to the post-operative ward. And so one of the things that we did was to propose that they expand onto an additional level that had yet to be built out in order to properly build out the level of newborn services that they needed and fully provide all of the spaces that are required to support the unit, as well as provide the number of postpartum and labor beds that were really required for that volume of birth, while keeping delivery and OT where they were planned. Because as you mentioned, Bruno, it doesn't make sense to not use the investment that is already being there put in there. So it doesn't make sense to move the OT, but we did propose expanded delivery rooms, and then building out this additional floor. So just walking you through this quickly. Often we talk about a small and sick newborn unit, but very commonly it's treated as one room. But if you really think about a unit, it really needs to be have the proper donning and doffing spaces, milk preparation, kangaroo care, etc. All these bathrooms, all the spaces that are really needed for a well-functioning unit to perform, and then providing more well-spaced out beds. So every woman has one bed with privacy curtains, close proximity to nursing, et cetera. All of these things that are necessary, for example, too, in getting women to not only come, but to stay, to Pierre's earlier point, because we commonly see women leaving just a couple hours after birth if they're in very hot, stuffy, crowded spaces. So here we have tried to reduce the number of beds per ward to 4, and provide more intimate and well-spaced approaches to the ward interiors. And here's just a view of what that might look like going out to the balcony, where we proposed planting some shade vines in order to provide additional shading and privacy as well. This next example is a hospital in Addis Zemen in Ethiopia, where it was already a series of buildings on a hillside. So there was this one building that had a lot in it. It has the OR, complex OR and delivery, staff spaces. All of the maternal beds are here in labor and postpartum, and in the corridor. A small newborn unit here in KMC, and then over here was a makeshift space with a men's ward in it. So as you can imagine, this is a very crowded space, many different functions, very tangled, not ideal in terms of airflow or privacy or anything really, and not ideal to be near this men's ward either. So the proposal here was to build out the additional spaces that are needed, keeping delivery and labor in here with proximity to the OR, but building out, this was one of the facilities that had been identified as strategic for an expanded NICU, and then creating additional postpartum spaces on as well, tied together with a circulation stair and ramp. So here, keeping the OR where it was, providing additional labor and antenatal wards that had enough space for labor walking in this private corridor, spaces for delivery and staff spaces, as well as postpartum wards that were designed around that concept of community. So as you may remember, in Ethiopia, we found that access to spaces for traditional coffee ceremonies were more important factor of getting women to come and stay than even access to emergency transport. So we designed the landscape with these seating nooks such that families could hold these coffee ceremonies adjacent to the postpartum wards. And then also designed an expanded NICU ward. And one of the things here that I just want to point out are these thicker walls. So in an effort to reduce the cost of imported materials and also celebrate the traditional stonemasonry that is common in this area, we put these large walls kind of longitudinally down the building, which wouldn't be exposed stone on the inside. They'd still be plastered over on the inside for, to create the proper medical environment. But on the outside, you could see that materiality. It would also be a more effective approach, cost-effective approach to construction as well. And here's some renderings from the exterior of the building. This hasn't been constructed yet, but seeing how you could put in retaining walls to create some of those spaces. And this is the kind of ramp and stair connecting the buildings. In Kakamega County, Kenya right now, we are supporting our amazing partner, Jacaranda Health, which is working on rolling out their service delivery redesign work in the second phase in several hospitals across the county. We did a really wonderful human-centered engagement and assessment process with them to listen to end users about what great and respectful care would look like, and identifying as well some of the kind of technical building systems that needed to be improved. And because we are working on a series of facilities across different sites, the approach there that we landed on was to really think about this kit of parts approach of designing postpartum and labor wards and delivery wards and ORs as a series of almost puzzle pieces that could be reconfigured appropriately to the different sites. But what they have in common is really trying to think about aggregating these spaces around a protected, intimate labor courtyard, and creating a space that feels kind of sheltered from the rest of the facility, but also enables the kind of proximity and flows that are necessary for smooth care delivery as well. So here's one rendering from the top that shows how this might look from an aerial. And here's a view showing some simple things that you could do to provide a really nice labor walk for laboring patients. Privacy screens to try and kind of shield views to different spaces, benches for mothers to rest, and walking paths that could be simply made of gravel. And here's a view of the inside, trying to accommodate natural light and ventilation, include companions in the spaces, and provide the sinks and other amenities that are necessary for care. And this is an image showing how those modules or kit parts would be adjusted to the different sites that we're working in as needed, which range in terms of their size and program. So the one that we showed is the most fullest program with an OR, and some of them already have existing buildings that we're attaching onto to try to make use of that inherited infrastructure. And then also certain schemes are not ready to be fully built out, but have space and kind of forward thinking about how they could be added onto in the future. And this last example was from a few years back before we began working with IHI. It's a maternity waiting home, or what we call a village, in Kasungu, Malawi, where we began working with the Ministry of Health on the question of how to improve maternity waiting homes. So the problem was, I think many of you might be familiar with the idea of maternity waiting homes and getting women to come with high-risk pregnancies to come and stay next to a hospital in the last weeks of their pregnancy, so that when their time comes, they're not too far away and they can receive the care that they need in time. But often maternity waiting homes are designed as a big, almost cattle barracks, or army barracks, where you have, in this case, 36 beds stuffed in one hot, dark, stuffy space. So women weren't coming, and if they came, they would just have to sit around outside with all of their stuff and their companions. is very uncomfortable. So if you think about, the term maternity waiting home, well, what is home? And if you think about waiting, how can you transform waiting from something that is a loss, from something that is boring, whether you have nothing to do, into instead a positive or community building experience? And so taking cues from the local context, we designed a village or a series of smaller buildings with more intimate sleeping quarters, 5 beds each, and also made sure to accommodate the companions by building in benches for them to sleep in at night, sheltered by the large overhanging eaves, as well as spaces for cooking. So this is a scene that you might see in the center courtyard of women gathering for celebrations, for kind of educational or training events, and really just supporting one another in this collective experience of becoming a mother. And afterwards, we did an evaluation, surveying 600 women at the standard existing facilities versus the new one, which really looked at how the new design did increase the experience and thereby the utilization of the waiting homes. And here I'll just pass back to Manara after showing you some of those examples. So, Manara, right?
Thank you so much, Amy. And we'll pick up the point around cost perhaps a little bit later. And Amy, we might need to just explain a little bit about how the costings of some of these facilities work. But would you like to touch on that now in relation to Malawi, or would you want to do that later?
No, I think this is just the lead in to the wrap up. That's just about, to really create transformative change, we need to challenge what we know and really, support the idea that we don't have to just keep on accepting the poor facilities that we've inherited. Yes, it's true that there isn't, endless reserves of money to transform these overnight, but we need to start shifting the needle by championing longer term investments in the built environment. And one point that I'll make about some of those case studies that I showed for the Bangladesh one, for example, we led a workshop where we showed the government stakeholders, here's a kind of Band-Aid short-term approach where you could just make a couple tweaks. Here's a medium scale approach, and here's a longer scale approach that wouldn't require building out a whole new floor. And they discussed amongst themselves, the pros and cons of those different scale, those different levels of intervention, and they themselves decided that they wanted to do the longer term approach because they recognized that continuing to do the Band-Aid approach was not going to lead to the outcomes they wanted, nor be cost effective in the long term. So I'll hand it back over to you here.
Thanks, Amy. So next slide, please. So again, returning back to systems, staff, stuff, and space. Really, I hope we've, throughout the last kind of 60 minutes or so, been able to really share around the space, the importance of space, the case for space, how it helps, supports clinical care, quality improvement, how we can honor culture, we can honor the birthing process, we can honor everything through thinking about space, but at the same time ensuring better outcomes, care outcomes for mothers and babies. So really including space is kind of non-negotiable as we move ahead and we think about the work that we do. Next slide, please. But we've also heard today around sustainability, and the piece around climate change is just so important. And as we are working with many low middle income countries where, we can't afford to have air conditioning running, we can't afford to have all of the lighting on all the time. We have to look at natural lighting, natural ventilation to help support the designer for some of our facilities to really think about sustainability. And again, I think going back to Bruno's point and the earlier conversations, so important for us to think beyond just the construction, and really think about how is that building going to be sustained? How is it going to be maintained? How is it going to be managed beyond the construction process? Next slide, please. So bringing us back to where we started, we hope that we've made some case to really, for us all to think about as healthcare professionals working in the global environment, that really to fully achieve quality of care, to ensure that all of those benefits are achieved for our mothers and newborns, that we do need to create a global movement. We need to think of this at a system level, not in isolation, really integrating space into care delivery, into the functional environment, into the climate and resilience plans for our countries and health systems, to really think about how we improve healthcare infrastructure. So integration is what we're thinking, not isolation. We don't want to see standalone buildings going up tomorrow, which are M&H units. We want to think about how we can integrate those into systems to derive the most benefit. Next slide, please. So how do we take some of this forward? We have been having some conversations globally around with different partners on how we can manage some of this. SDR and systems thinking is a real opportunity to integrate space into that thinking and that planning. We've also been talking to WHO around developing some space standards around primary care, around secondary care, around different aspects of the maternal newborn pathway. But having some space standards may well be one route that, even if it doesn't happen within the next 6 months, within the next 12 months, but at one point when those buildings are refurbished, when those buildings are reconstructed, these standards will be taken into consideration. The Delivering More Toolkit in itself is a resource, and we're really happy. Our organizations are happy to provide advice and guidance on the toolkit and take some of this work forward. So I think there are real opportunities to do that. The time is right. There's a lot of construction happening in healthcare. The pandemic has taught us that, we need to think about infrastructure. We need to be more resilient and be prepared. And some of this is now the right time to really start the conversation. So thank you very much. And we hope that together we'll be able to deliver more and do better for our mothers and our newborns. Thank you so much.
Great. Thank you, Minara. Thank you, Amy. Thank you, Pierre. Really appreciate it. Of course, we're running out of time. We have a question, also from Bruno. Did you measure the effects of the new designs in terms of utilization, outcomes, patient satisfaction, et cetera?
Yeah, for
Amy,
that
would you like to take that?
Sure. We did do that for the maternity waiting village. I think we would love to do that. The problem is always funding. For that one, we ended up finding a grant and also self-funding a portion of it. But yeah, I think it's very difficult to find funders who are willing to invest in bricks and mortar. And it's also hard to find funders who are willing to, or partners who are willing to pay for the cost of evaluation as well. But it's definitely important. As you're saying, it's kind of a negative feedback loop right now, because without the evidence, there isn't the proof to invest, and without building out the proof and investing in that, then that cycle is very difficult to complete. But definitely champion your call for more evidence and more research.
Thanks, Amy. Other questions in the last few minutes? I hope I'm seeing hands. Great. I'm not seeing any questions, but if you do have some, please send them through the community of practice and we'll pass them over to Minara, Pierre, and Amy. I wanted to just take 1 minute to loop this back to how we're thinking about service delivery redesign. So for SDR, we think about 5 buckets of interventions: improving life-saving care, improving primary care, improving access, aligning your policies, and engaging with communities. I think the work that IHI and Mass Design are doing are a key part of both the life-saving care and primary care, and access actually also with maternity waiting homes. So what I would encourage, as Minara was saying in her closing remarks, is to think about structure and infrastructure when you're thinking about service delivery redesign as part of a set of interventions to improve care for moms and babies, especially the most vulnerable. So not a standalone intervention. Nothing is really a standalone intervention. These are complex issues that require attention from multiple perspectives. So with that, I will pass it over to Amy. Thank you.
Thank you, Sana. Thank you all. What a wonderful presentation. Thank you to our speakers today. A lot of insightful information that was shared today. Obviously, our time is always short, but I am sure our speakers remain available should you have any more questions. So once again, thank you, Minara, Ms. Minara Chaudhuri, Ms. Amy Chow, and Dr. Pierre Barker. Our moderator, of course, Dr. Sanam Oradewam, my colleagues Kate and Kojo, and behind the scenes, our producer Victor and the interpreters that we cannot forget, Amory and Carol, and all of you for being here today also as well. A quick reminder, please keep an eye on our upcoming newsletter for more resources, announcements, and of course this recording. You will also receive a webinar brief, and it's called Delivering More Designing Material and Newborn Spaces for Quality of Care. It was already shared through the chat, but in case you are not able to download it, you will also receive it in our upcoming newsletter. So with that, I wish you a lovely rest of your day, afternoon, evening, and hopefully see you next time. Feel free to turn on your cameras and unmute yourself to say goodbye to everyone. Thank you so much. A pleasure. Bye,
Thank you.
everyone.
Thank you.
Thank you all.
Thank you.